Today we're going to be talking about ultrasound in the evaluation of a patient who has a fever. This was sort of an interesting request that I had from the deans of the curriculum, and they asked me if I could integrate ultrasound somehow into their fever module, and I thought about it for a while, and naturally I turned to the literature whenever I have a question, and there was this paper here in another language where they talked about the value of a standardized ultrasound in patients with a fever. So I reviewed this paper. They found 200 patients examined with a fever using ultrasound, and they said some funny things like they looked at their collar, which I presume is their cervical region, their thorax, their heart, their abdomen, and some of their small parts, which you can imagine what that means. So, and they actually got some pretty interesting data. Over half the time, they were able to find the source of the fever using ultrasound, and in 12% of the time, they detected an unexpected source for the fever. And I always make that joke about ultrasound that if there was a journal called the Journal of Unexpected Ultrasound Findings, I could publish in it all day long because I'm always stumbling across things, not just in patients with a fever, but all kinds of other clinical things whenever I'm using ultrasound. So in their paper, they pointed to the parts of the body where they were able to find stuff wrong with them, and we're going to go through some of this stuff right now: the head and neck, the lung, the extremities, and the abdomen. So starting with the head and neck, this is what an abscess looks like on the face. Even a small lump on the face, you're wondering what it is. It's kind of red, it sort of hurts, and you could see this debris in here where if you were to compress it, it could swirl around. You want to be careful whenever you drain an abscess to stay away from vascular structures such as here. We're seeing both color flow and pulse wave Doppler. We can see these vascular structures. Look how close that abscess is to that vessel. You'd want to be careful doing that drainage. This is a condition here called conjunctivitis, you probably have heard of, and you get this red, irritated conjunctiva. It's sort of typical of the infection. Patients often complain of burning or gritty, foreign body sensation in their eye. There's usually a watery, mucoid discharge. They get some morning crusting, very common complaint. We see this all the time, all over clinical medicine. And the lids get red, they get swollen, and you can sometimes palpate some pre-auricular lymphadenopathy. Right in front of the ear, you can sometimes palpate that. Those pre-auricular deep parotid lymph nodes in the anterior auricular glands, or sometimes called the pre-auricular glands, they number from 1 to 3, and they lie immediately in front of the tragus of the ear. And their afferents drain the lateral surface of the auricula and the skin of the adjacent part of the temporal region. Their efferents pass to the superior deep cervical glands. Now, symptoms come on often begin and predominate in one eye, and then within a few days have spread to the contralateral eye. A history of an antecedent upper respiratory infection or anybody having close contact with somebody with red eye is almost invariable. And they get a fever. They get this fever when you have these pharynx and conjunctival symptoms along with the fever. That usually describes this adenoviral conjunctivitis, and the additional systemic symptoms, the sore throat, the fever, the headache, that's all very classic with conjunctivitis. So once again, just to be clear, when you see a pre-auricular lymph node there in front of the tragus, and we can confirm that using ultrasound in patients who sometimes are difficult to examine with the physical exam, when we see those pre-auricular lymph nodes there, we know that this is likely a viral cause to their conjunctivitis, and therefore do not need antibiotics, at least initially. Now, another place where ultrasound is useful to distinguish between a bacterial infection or a viral infection is with mononucleosis. With the cervical nodes in the neck, you get the lymphatic flow there involves draining the superficial and deep structures of the neck, all structures of the oropharynx, nasopharynx, scalp, the esophagus, the thyroid, larynx, trachea, even the pectoral region of the arm, and even parts of the lungs will drain through the cervical nodes. And so with infectious mononucleosis, there is usually bilateral cervical lymphadenopathy, as you can see here in this image here where these lymph nodes are, and this may be happen acutely or extended over a longer period of time. Patients with infectious mono often have accompanying systemic symptoms like fever, fatigue. On the physical exam, you usually see some exudative pharyngitis, generalized lymphadenopathy, hepatomegaly, splenomegaly. The organs start to get larger. The organs in the upper abdomen start to enlarge. And patients with bacterial infections, on the other hand, usually have unilateral cervical lymphadenopathy. The bacterial cervical adenitis is usually preceded by an upper respiratory infection like pharyngitis or otitis media. So again, infectious mononucleosis, you're looking for bilateral cervical lymphadenopathy seen here. The other thing you can look for is with the spleen as well. And an enlarged spleen you can see it here, measures anywhere between 11 and 20 centimeters in its longest dimension. That's considered enlarged, anything greater than 11 centimeters. And if you look at the 1 centimeter hash marks over here on the side of the screen here, definitely this thing is measuring out over 11 centimeters. Once you get greater than 20, that's considered massive splenomegaly. But a moderately enlarged spleen with unilateral cervical lymphadenitis really does suggest infectious mononucleosis, which of course does not need antibiotics. Now, another example here of some submandibular lymphadenopathy here in the head and neck, and somebody with a fever. You get these hot, swollen, tender, supple lymph nodes. Usually, these structures are also associated with, fever, fatigue, muscle aches. Can be caused by a whole host of things: Epstein-Barr virus, cytomegalovirus, cat scratch disease, tuberculosis, and of course the bacterial infections being the most common. So we're going to talk about the peritonsillar region here now, up in the head and neck, and you can see the tonsil here on this diagram, and there's various peritonsillar spaces. There's the retropharyngeal space, this being the vertebral body here. You've got the retropharyngeal space, and you've got the parapharyngeal space, and so this parapharyngeal space is really what we call the peritonsillar region that we worry about an abscess and being able to see it on ultrasound. You can also see the abscesses here in that retropharyngeal space, but most commonly they're in this parapharyngeal peritonsillar region. And so when we have an abscess there, we need to be able to get at it somehow. And if you take a specially shaped transducer here that's normally used in the endocavitary or endovaginal area, of course you don't want to call it that around the 12-year-old male you're doing this on, but you want to place a sheath over it and place gel between the sheath and the probe. Right in this region inside here, and then you can spray the back of the throat with some of this lidocaine spray. The transducer then in the posterior oropharynx, what you see in somebody who has a peritonsillar abscess is this right here. You can kind of rotate or twist the probe through the tonsil. You want to compare both sides and look around. As you push on any soft tissue abscess, you'll get some, quote, pulstalsis. It's kind of like peristalsis, but it's for pus, I should say pustalsis, where you'll see some swirling debris in there. And just some more examples here of some peritonsillar abscesses here. You can see this very large region back here in this patient's throat. We can see them quite easily on ultrasound. You want to make sure, though, that you're not looking at lymph nodes. Lymph nodes can look a lot like a peritonsillar abscess. However, when you put flow here, this is power flow, we're placing it on that lymph node, just confirming that we're not actually looking at lymph nodes. And in this case we are. This is a very hyperemic lymph node that you see, as I mentioned previously, when you have any kind of infections around the head and neck area. Certainly with somebody who's got a raging pharyngitis going on, bacterial or viral, you'll see sometimes lymph nodes in that peritonsillar region that light up pretty well. So that's where ultrasound can be really helpful, is determining whether or not you're even looking at a pus pocket to drain. This is a pus pocket before drainage here in that peritonsillar region, this hypoechoic swirling debris. And then after the drainage is done, you see that most of the anechoic material is gone now, and you're just looking at this space that's no longer filled by that abscess. Another example here of an actual guidance. So you're guiding the sharp object, the needle, down into the abscess here, and you can see I froze it for a second. Here's this comet tail artifact coming down. It's a reverberation type of artifact we see from the metallic needle that's going through the in plane of the ultrasound beam, with the needle tip seen here entering into that abscess area, and then you can aspirate out the pus, and you can see the pus kind of moving in towards the needle tip there under ultrasound guidance. And then after aspiration again, once you've got the abscess out of there, you can see that there is nothing else to aspirate there. Moving on to an infection that you could have in your brain, like meningitis or encephalitis, where you need to acquire cerebral spinal fluid in order to make the analysis. And when you get in that situation, you got to get the needle here in the back between the two vertebral bodies. And so you can see one transverse process of that's this with the spine shadow overlying the rest of the vertebral body. Over here you can see the other spinous process with the spine shadow overlying the vertebral body. And this is the posterior aspect of the patient's back here. The needle should go between these two in this space here, in this potential space. And so again, here's those vertebral bodies, and then your needle is going to be entering in between this potential space here. And so that's where we're going to be trying to do when we do this procedure. Now, you're not actually going to guide a needle under ultrasound guidance like you just saw in that peritonsillar abscess, but instead, all you need to do is mark the patient's back. You want to mark where their spinous processes are. So this is kind of a typical patient's back. It's few centimeters until you get down to where the spinous process is. Very hard to palpate this landmark using just the physical examination. So ultrasound is helpful here to just find the spinous process. So as long as you could find the midline of the back, I take a pen and I mark several of the spinous processes going up and down the back here. And once I get that area marked out, I know the true midline of this person's back. And then I take the spinal needle and I just insert it between two of these spinous processes until I either reach spinal fluid or I reach bone. If I reach bone, I back the needle out, not all the way out of the skin. I back it up a little bit so that I can go aim a little bit more cephalad, hoping to go between two of those vertebral bodies. So that's how ultrasound can help find the location to do a spinal tap in somebody who could potentially have meningitis. We're going to switch gears now big time and talk about pneumonia. Ultrasound is very good for pneumonia, as you've heard me talk about before. The main thing is to locate, to decide whether or not we see A lines or something else. Now, normally air does not conduct sound very well. Air is sort of the enemy of ultrasound. And so when when sound enters the chest, it encounters the pleural line. And the pleural line is where the visceral and the parietal pleura come up against one another, the VPPI. It's where the lung is up against the chest wall. And we can see that lung sliding back and forth as long as there's no collapsed lung, as long as there's no pneumothorax. We can see that pleural line very easily. What happens, though, in normal individuals, the sound encounters the pleural line, bounces back, and you get this artifact that comes down here, equidistant from the skin line to the pleural line. You'll see these A lines. A lines are normal. They stand for air. Everything is all right when you have A lines, generally speaking. Now, you could have A lines in somebody who's got COPD, but the bottom line is you look for these A lines here to differentiate patients. You could have another type of pathology, such as when fluid replaces the air in the lung. And so when fluids such as blood or pulmonary edema, infection, contusion, tumors, things like that, replace the normal air that's in these spaces in the lung, then the sound can then be transmitted through the lung, which is abnormal. And the place you're going to look for the various types of pathology we look for in the lung, such as pneumothorax, we look very anteriorly up here in zones 1 and 2. And what we're talking about in this podcast, though, is pneumonia, infection, fever. So you're going to look in the more posterior lateral zones when it comes to looking for pneumonia. And so what is pneumonia? What is a consolidation? You hear us use these terms all the time in medicine. There's a consolidation here on the chest x-ray. A chest x-ray is a very non-specific way of looking at a consolidation. So this could be a consolidation. This could be a big pleural effusion. Hard to tell with just a chest x-ray. But with ultrasound, we can see these consolidation, these pneumonias. They look like hypoechoic, wedge-shaped areas with air bronchograms that appears hyperechoic within that consolidated parenchyma. Even in severe cases, when you get a big lobar, a whole lobe of the lung is taken out by a pneumonia, by an infection infiltrating the area, then you get hepatitization, or the lung can actually look like your old friend, the liver. So I'll show you some examples of that right now. Other things that can cause loss of aeration, as I mentioned, in addition to having a lot of pulmonary edema here. The pleural effusion would be pulmonary edema, a pneumonia, a big contusion of the lung, and the lung can collapse a little bit as well, what we call atelectasis, and or poorly aerated parts of the lung where suddenly on a chest x-ray you can just see loss of aeration. But on ultrasound we can differentiate what a pneumonia looks like pretty readily. Do you see any A lines here? I certainly don't. I see what looks like almost the liver here, and this is what pneumonia looks like. This consolidation is picked up very readily with ultrasound. You get this somewhat hypoechoic area with some hyperechoic lines, horizontal lines in here. We see these horizontal hyperechoic lines moving along. These are all what appear to be the beginnings of an air bronchogram. Fluid bronchogram on ultrasound. We call them air bronchograms on chest x-ray, and sometimes I slip up, but fluid bronchograms on ultrasound, these horizontal artifacts going back and forth. By the way, Jacob Avila, amazing up-and-coming ultrasound expert in emergency medicine, works in Kentucky, and did his fellowship in Kentucky, and now he's in Tennessee. And he has this cool website called 5 Minute Sono, a lot of good stuff on there. And I saw some stuff recently he put together, and I just couldn't help but ask him if he could share those with me to show my students. Again, more stuff from Jacob here. You could see what looks like a pneumonia here with some raggedy, shaggedy borders going along, and hepatitization of the lung. This looks like liver, actually. When you look at this, it really looks like liver to me, but this is just a socked-in pneumonia you're looking at here, as opposed to A-lines. I mean, this is the pleural line up here, A-line, A-line. Look at the difference between these two chests. Very obvious to see what pneumonia looks like here in this patient. Now, those fluid bronchograms, as I mentioned earlier, it's fluid seen between two horizontal lines. When you see this here, this is very specific for pneumonia. It's fluid in the bronchus in somebody who's got pneumonia. You get these blurred margins and hyperechoic horizontal lines. And when you let the video clip go, you can really sort of make out those fluid bronchograms sliding back and forth. Different than A lines. Remember, we're not even seeing the pleural line anywhere in here. We're not seeing equidistant horizontal lines. We see some horizontal lines with anechoic fluid seen between them right there. That's what a fluid bronchogram looks like in pneumonia. Another example here, normal A lines, and then over here we have this patient with pneumonia. This is one I picked up during rounds with third-year medical students that I do with Dr. Butera in internal medicine hospitalist service. Every few weeks we go up there, and this is a good example of a patient who's admitted with pneumonia. Again, you can see these fluid bronchograms here and hepatitization, loss of the A lines. Another example of pneumonia here, this patient hepatitization of the lung. It's a very consolidated type of pneumonia seen here. Over here, it looks like almost normal lung. I see some pleural line here, maybe A line, maybe another A line down here. This part of the lung is actually looking okay to me, but the part of the sound that's going through this part of the lung over here where this pneumonia is, we can see that hepatitization of the lung going on there. Okay, so we talked a little bit about soft tissue cellulitis up in the face and the head and the neck, but we're going to talk about now in the extremity. So we're switching gears now and talking about the extremity for cellulitis. And I should back up a little bit and tell you that whenever you kind of place a transducer on somebody's infected skin, you're looking to differentiate a skin infection from a deeper soft tissue abscess, you want to put a Tegaderm on the transducer. It protects the transducer, it protects the patient from the transducer as well. You don't need any gel between the Tegaderm and the transducer the way you did between the sheath over the endocavitary probe. So this Tegaderm just plops right down on the it's very sticky. It sticks right down to the transducer itself. This was a patient of mine who came in, very well known to the emergency department, super nice guy who comes in and says, look, I just need this abscess drained right here. He's clearly had a lot of other abscesses here from using intravenous drugs. And he said, look, doc, I'll be out of your hair. Just drain this abscess and I'm out of here. And normally, without ultrasound, I would have kind of palpated this area, felt some induration, some thickening, and gone, yeah, there might be an abscess there, we'll take a look. But after we did this study, we had, I don't know, about 120 cases or so, and we had 18 cases in which the ultrasound disagreed with our clinical exam, but the ultrasound got it right 17 out of the 18 times for a pretty significant p-value. It made me realize that, maybe ultrasound is better to decide when to, cut into somebody's skin or not to. And so in this particular patient here, I did an ultrasound on him and found that all he had was cellulitis. So this is what cellulitis looks like. It's just cobblestoning here. There's no reason to cut that open, no reason to put a needle in it or open up with a scalpel. All you do is give the patient some oral antibiotics. And so that's pretty straightforward. These cobblestones become outlined with a little bit of edema. They get hyperechoic because they're getting more dense now from the infection. This is what normal soft tissue looks like over here. You could see, actually this is hard tissue, this is bone here and some other normal soft tissue. And on this patient though, they've got some cobblestoning going on here. You can see these little cobblestones outlined by the free fluid. This is what cellulitis looks like over here. Normal tissue, cellulitis. On the other hand, this is an abscess. You see the swirling debris, hypoechoic swirling debris. We talked about pustulosis. You can see it almost looks like it's peristalsing or pustulsing as we push on it. And that helps differentiate that from just other thickened material that can be in the area there. This is abscess, this is cellulitis. Cobblestoning, this is pus, swirling debris. As I push on that debris swirls around. Another example here, this patient, we couldn't tell what was going on. Turned out they had a deeper infection. I switched it up to the curvilinear probe and we saw this pus down here. Isolated out in this shelled out area. With the linear probe, high frequency, the frequency was too high to see the deeper abscess. We had to go to a lower frequency curvilinear transducer to see the pus swirling around down there. Another exam here in somebody's perineal area, and they had this hypoechoic swirling debris here. Another patient who has some cellulitis that's actually deeper to the abscess. So you see the abscess up here, this hypoechoic material, and then we see the cobblestoning down here underneath the abscess, followed by normal striations here of muscle fiber stretching out across the screen here. Now, it starts to make you wonder, hey, can we see necrotizing fasciitis? This sort of polymicrobial is super aggressive infection that spreads quickly through the fascial planes. This is a surgical emergency. They need to go straight to the operating room and have this debrided open. It's hard to tell which patients have it, which ones don't. The physical exam can be misleading here. It ranges the whole spectrum from being very hyper aesthetic, very painful, to being actually not tender at all. And so it's somewhat difficult to determine on the physical examination. We turn to imaging. MRI does very well here, but MRI takes at least an hour to perform and read. So it'd be great if we can do something at the bedside. And certainly we can. Ultrasound, and Dr. V. Din, good friend of mine at Loma Linda, does a lot of amazing things up in the ICU. He's trained in both emergency medicine and in critical care. And he does a lot of good work, what he calls the staff exam, which stands for subcutaneous thickening, ST, A is the air, and then fascial fluid. And that's what he describes as necrotizing fasciitis on ultrasound. I've got some examples of that here. And what you're going to see is, this is straight out of his article, and you can see certainly the air seen up here, subcutaneous thickening up here. The subcutaneous space got thick, and then underneath it you can see the air with the shadow coming down. And that's basically what you got. And if you go to the edge of that, you start to see some fascial fluid, some hypoechoic, anechoic fluid seen in that fascial plane as well. So when you see that subcutaneous thickening and you see the subcutaneous air, maybe some fascial fluid, that should raise your suspicion for necrotizing fasciitis, a true surgical emergency. We've seen a lot of that here in the emergency department, UCI. Some examples here. You'll see some subcutaneous things, definitely some air. I see a lot of air in this particular abscess here. That always makes me think about neck fasc. We also see a lot of subcutaneous thickening and some subcutaneous air here in the beginning of that one. We see air here deep to the muscle here. Here's the muscle up here. Here's all this air. Air looks like hyperechoic punctate dots on the ultrasound screen, followed by sometimes bright, sometimes dark shadows. The shadows can be variable. But certainly when you see that hyperechoic punctate dots, that's all air down here in this deep muscle abscess. Makes me very concerned about. And this patient had necrotizing fasciitis of her bicep area. This is another patient that's got some foot cellulitis going on here. And then when you look a little bit more superficial to this foot cellulitis, you can see some air going on. Let me go back to that. Oops. Go back to that one here. And yeah, that was that muscle. Here's that foot cellulitis. And boom, there's that air right up there. You can see that air coming across right there. Hyperechoic, a little bit fuzzy border here, but the brightest thing on the screen, many times it's punctate. That's what air looks like on this guy's foot who had necrotizing fasciitis. And sometimes people just have an enlarged lymph node. An enlarged lymph node can be the sign of either lymphadenitis, ascending lymphangitis, or just there's an infection somewhere and you got to find it. So in patients who come with a red, swollen leg, sometimes we're wondering about what's going on with their leg. Is it a DVT or not? And meanwhile, we find all these swollen lymph nodes, and then we compress for DVT. There's no DVT there up and down the leg, but we do find these large lymph nodes, and that confirms the presence of a distal infection like cellulitis or lymphadenitis or lymphangitis, depending on where we find these lymph nodes and how extensive they are. You put some power flow Doppler here on this lymph node, you see the whole thing just light up like a Christmas tree. That right there is a hyperemic inflamed lymph node, consistent with an infectious process either going on locally if they're tender over that lymph node, or distally if you see a lot of redness on the skin. Changing gears now to a genitourinary ultrasound. The kidneys, we'll start there. This is what pyelonephritis looks like. It's a hyperechoic kidney. This is different than the kidneys that you guys are used to seeing. And you can see this hyperechoic kidney there. It doesn't have that nice hypoechoic cortex to it. The whole thing is very echo bright. Look at it compared to the adjacent liver here. So that's what pyelonephritis can look like. Pyelonephritis, however, is a very, very, generally speaking, clinical diagnosis. You do a little CVA tenders, boop, they jump off the bed, you check the urine, it's positive. Maybe they have some fever with some vomiting. Pyelo. This is what a renal abscess looks like here. This is an abscess that's seen just off to the edge of the kidney. What we're looking at here is, I should say, this is the normal aspect of the kidney. Down here is the upper pole of the kidney. We can see that its renal cortex was seen on that outer aspect of it. And we see over here, this is what all the abscess is here. This patient came in with a lot of fever, tenderness, and we thought, well, it's probably just pyelo. But then as we started looking with ultrasound, we found this huge area out here within the kidney. The kidney actually extends from here. Here's the renal cortex out here. The renal pelvis is seen in here. And as you extend this kidney along, boy, it's got this big abscess that's extending all the way out here. That's what all this material is here. This is some hypoechoic debris seen inside this abscess in this patient's kidney. Do you think it's a right or left kidney? I bet this is the spleen. It doesn't come all the way over like the liver tends to. So I think this is probably the left kidney if I had to guess. And this is this big abscess here on that left kidney. What about the bladder? With cystitis, usually the bladder actually looks pretty normal. However, sometimes you can see some thickening of the bladder wall. Anything greater than 3, maybe 4 millimeters is considered a thickened bladder wall, and that can go along with having chronic urinary tract infections. Certainly, you can get some focal calcifications in the bladder wall. That leads me to think of chronic cystitis. Occasionally, you do see some intraluminal echogenic debris swirling around, though you can have debris in patients who don't have urinary tract infections, interestingly enough. Talked about actual stones, not just within the wall, but within the lumen of the bladder. And patients who have enlarged prostates, there's a continuum of infection there with their bladder. And occasionally you'll have patients with enlarged prostates who have urinary retention and very high post-void residuals. This is what a pediatric patient came in with cystitis. You can see these are 1 centimeter hash marks here. So the bladder wall is definitely more than 3 or 4 millimeters in thickness. This is a little baby who's got chronic urinary tract infections from incompetent valves, and you get these thickened bladder walls here in someone like that. Also, in the genital urinary system, we do have the testicle and the epididymis, and you get this also sort of a continuum of infection from starts as epididymitis, and then it becomes epididymo-orchitis, and eventually orchitis really sets in, and you can even get intratesticular abscesses. I'm not sure what's going on with this testicle here, but it does look like it's looking up at its owner, wondering why does it hurt. And when you do get an infection in the testicle, when you put the power Doppler on there, you can compare the two sides, and you see this increased flow to the side with the infection. You can see that here. This is a orchitis, epididymitis going on here. You can see this epididymo-orchitis on this testicle as well. We're using power flow Doppler. It's a type of color flow, but it's not directional. It's more sensitive. And you can see if you hold the probe really steady, where our frame rate's really low right here with the power flow on. So you have to hold the probe really steady. You can see some thickening of the scrotal skin here, and some really bright hyperemic testicle and epididymis here on these patients. So epididymo-orchitis, ultrasound's a very useful tool to diagnose that. And as I mentioned, sometimes you can have an infection that goes inside, an abscess that goes inside the testicle. This is a testicular abscess here. This is another testicular abscess we came across over here. Hypoechoic, swirling debris. The testicle doesn't really compress very well when you push on it. Patients definitely do not appreciate that either. But if you can, move the testicle around, you'll see the debris sort of falling with gravity. Okay, moving on to the hepatobiliary system, and we've got the gallbladder. One of my favorite things to do an ultrasound on. A normal gallbladder wall is about 3 millimeters, and somebody with right upper quadrant pain, fever, vomiting, leukocytosis, elevated. Sometimes you'll see elevated liver enzymes and T-bilis. You're talking about cholecystitis, and that's what we're trying to figure out, cholecystitis. A normal gallbladder wall is 3 millimeters. Once you get up above 5 millimeters, certainly is definitely thickened and points to cholecystitis. This is an example here of really rip-roaring cholecystitis. And you can even have ascending cholangitis, which in older individuals has a very high mortality rate. And in this particular patient, they had ascending cholangitis, a very thickened gallbladder wall here, seen with the stone in the gallbladder, some intrahepatic ductal dilatation of the biliary system as well. This is a very, very sick patient. Here's your CBD, very dilated here. Another example of cholecystitis, we see the thickened gallbladder wall here, we see the stones, and as the clip goes here, you can see as we fan through a very thickened gallbladder wall, again, 1 centimeter hash marks. This gallbladder wall is like 1.2 centimeters, definitely thickened more than the 3 millimeters that is the normal. Another example here of another patient with acute cholecystitis. We see the thickened gallbladder wall, we see the stone with the shadow, even some adjacent pericholecystic fluid. Within the liver, we can see abscesses, different types of abscesses. You can see bacterial abscesses, sometimes other etiologies, such as fungus can cause abscesses in the liver as well. When you do have an abscess in the liver, the mortality can be quite high, up to 30%. The prevalence of liver abscesses has essentially remained unchanged over the years. Untreated, again, this can be a very fatal infection. In fact, untreated, it's 100% mortality. The three types of abscesses that you are likely to see in the liver. Here's another example of one down here. Pyogenic abscess, polymicrobial. This accounts for about 80% of the hepatic abscesses we see in the United States. There's amoebic abscesses from Entamoeba histolytica. That accounts for about another 10%. And then fungal abscesses, about another 10% due to Candida species. And what we're seeing here, we're trying to put some flow. We're wondering what we're looking at here. If you, as the patient's breathing in and out, sometimes you'll see some flash artifact, but generally speaking, you shouldn't have an abscess light up with flow. I think they're maybe worried about some kind of vascular thing going on here, but abscess is just a shelled out area that has a lot of infection going on, and that's essentially what they're looking at here in this liver. Now, also in the liver that can cause you, or in the abdomen that can cause you a fever due to the liver, is ascites. Now, just straight up transudative ascites, you see that usually from patients who have cirrhosis, hepatic failure, hepatic venous seclusion, constrictive pericarditis can cause this, kwashiorkor, cardiac failure, alcoholic hepatitis, or even liver metastases. You get this anechoic transudative looking picture. However, when you have malignancy or infection, patients with fever and ascites, I always worry about this. This is an exudative type of ascites where you can actually see the hypoechoic swirling debris in there. This can be, as I mentioned, from malignancy, but also bacterial, fungal, TB, pancreatitis can cause an exudative picture. So can nephrotic syndrome, or even a bile leak. So in either one of these cases, it's the next step is to do a paracentesis, particularly in somebody who's got a really distended abdomen that's starting to inhibit the respiration. You're going to do really more of a therapeutic paracentesis over here. Over here, if I saw this debris in a patient with fever, I would immediately do a diagnostic paracentesis under ultrasound guidance. So I don't accidentally poke one of these important bowel structures or hit the liver with my needle. So that's why anytime I take a sharp object directed in somebody's soft tissue, I'm going to use ultrasound guidance. But if somebody had a fever, I'd really be curious to see if they had an exudative type of ascites. Now, appendicitis, one of my favorite topics. You're going to compress with the linear probe in that right lower quadrant, looking to see if that appendix sneaks out and gets squished between the abdominal musculature and the psoas muscle. Sometimes you'll see it, it'll go away. You can freeze the machine and you can, cine back and try to see where that appendix was. But essentially, this is what you're looking for. Sometimes you'll see an appendicolith, sometimes you'll see appendiceal fat, and you're looking for a thickened appendix that gets squished down there. The studies are all over the place, but if you look at point of care ultrasound, bedside ultrasound, you look at some studies that have been done, the sensitivity is not nearly as good as a CT scan, but the advantage is there's no radiation, which is especially important in young people. But the better you get at doing this, the better you're going to get at doing this, and you're going to find that appendix. As you know from some of the hands-on studies that hands-on practice that we get to do in medical education, we can spend a whole hour with looking for the appendix, and we find it like every time we look for it because we spend so long looking for it. When I'm working in a busy ER, I don't have an hour to look for appendix. I give myself 5 minutes. If I can't find it in 5 minutes, then I might order one from radiology. If they can't find it after looking for 30 minutes or so, then depending on how other clinical factors, we may send the patient home and follow up in 12 hours or order a CT scan. But this is what appendicitis looks like. This is actually not what the appendix. This is what the terminal ileum looks like. You can see this cloverleaf-shaped pattern here. When I see the TI, that terminal ileum, I know I'm getting close to the appendix. It's right around here. So that's my tip-off. Whenever I see that cloverleaf pattern, I'm getting near the appendix. This is what an appendix looks like right here. This is the non-compressible tubular structure that measured, in this case, 1.1 centimeters. It got wedged between the psoas muscle and the abdominal wall musculature. Another example here of what appendicitis looks like. This is a fecalith here, blocking the lumen of the appendix. The lumen of the appendix where it connects to the TI was somewhere over here. This was the tip of the appendix over here. And you can see how it's getting very swollen from this stone, this appendicolith or fecalith blocking its entrance. Sometimes you put color flow on an appendix that's all inflamed. You get this hyperemia around the appendix. You can see that some more examples of appendicitis here. Psoas muscle down here. This is all pediatric appendicitis, by the way. That's why the pictures are so pretty. Using a higher frequency probe and getting almost no abdominal wall fat here on these younger patients. The ones you really want to protect from the ionizing radiation, periappendiceal fat. Here's that beautiful terminal ileum, that nice clover pattern I told you about. Adjacent to it is your positive appendicitis. Here's a fecalith, some hyperemia around the inflamed appendix. There's that TI again with your hyperemia around your inflamed appendix. Another example here, this is just some periappendiceal fat seen surrounding this particular appendix here. That periappendiceal fat gets inflamed, very typical to see that. And you also get the loss of some of those typical mucosal structures as the appendix gets more and more dilated. So to conclude, we looked at localization of a fever using ultrasound. We first looked up in the head and neck, looked at some lymphadenopathy and tried to differentiate bacterial from viral processes. We looked at the lungs for pneumonia, saw some beautiful pictures from my homie Jacob Avila. We also looked here at abscess versus cellulitis and neck fasc down in the extremities with our help from Dr. Din looking at fasciitis. And then finally in the abdomen, we had a whole host of things we can see in the abdomen, including renal abscess, cystitis, epididymal orchitis, cholecystitis, liver abscess, exudative ascites, and appendicitis.